Hi, this is Brian Kim. I want to share with you this case of a patient with dense cataract, and I'll be using the Johnson & Johnson Veritas phaco machine. And you're going to see the use of this phaco machine throughout this entire case and demonstrating some of the superior aspects of this machine, one of which is it provides excellent endothelial protection using the dispersive viscoelastic Endocoat. And also there's excellent chamber stability with this machine. And I'm going to share a series of cases and videos highlighting and demonstrating the benefits of using the J&J Veritas phaco machine. Starting with this case, I'm going to be performing terminal chop and then cross chop utilizing my standard technique. And I have a video overlay showing the fluidics and the use of the ultrasonic energy, which again demonstrates the no ultrasound, no vacuum technique when I'm performing the cross chop maneuver. And using the Endocoat bubble trap technique, as I've shared in my previous videos, demonstrating the superior corneal endothelial protection. So this is a cotton tip to steady the eye, and I use a corneal marker which will help me to center and size the rhexis. This is the 1mm paracentesis blade, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some Endocoat dispersive viscoelastic. And then using the Orlock technique, I'm controlling the eye. This is a left eye, and the patient has a Bell's reflex. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. I feel like this particular dispersive viscoelastic provides the very best corneal endothelial protection among all the dispersive viscoelastics that I've tried. This is a puncture style rhexis using the Moria microrhexis forceps. I puncture the center and I go around circumferentially. This viscoelastic does behave like other dispersive viscoelastics in the sense that it does tend to radialize, so you have to apply just slight inward pulling force as you're doing the rhexis to maintain the size and centration. But you can see I have excellent control and minimal OVD egress using this micro rhexis forceps. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, and then decompress, sweeping along the anterior capsule edge on the left side and then the right side. Decompressing the bag. And I decided not to spin the lens. I can spin it once I chop the lens. Irrigating the surface of the eye, adjusting the sleeve, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. And before I get started, let's review the overlay. On the left side, you can see the mode. In this case, it is in peristaltic quadrant. Keep in mind that J&J Veritas has both peristaltic as well as Venturi on all the different settings, and I have a hybrid for my settings, but I primarily use peristaltic for quadrant removal. This is the entire fluidic and ultrasonic overlay on the left side. It shows the current fluidics as well as the ultrasonic usage, and this indicates the total ultrasonic energy use. And these three bottom graphs illustrate not only real time, but as the time progresses throughout the case, you can see the movement of the graph, which is rather fascinating and an interesting concept to be able to, again, illustrate when I'm performing ultrasonic energy, when I don't use vacuum, when I do use vacuum. And as you know, with double chop and cross chop, there are going to be times where I don't use ultrasonic energy or vacuum. You can see this first mode, aspiration, and then the second mode is vacuum, and then the third mode is power. And you'll be able to see as I'm doing the case, because the x-axis is time, and you can actually see the movement of the graph as I'm applying the different forces using the pedal, my foot pedal being positioned 0, 1, 2, or 3. All right, so here we go. This is the case. I'm removing the surface epinuclear material. I'm turning the bevel up, and I begin the terminal chop maneuver by creating a nice central trough. But please first observe this tiny little bubble embedded in the endocoat. And that bubble will remain throughout the entire case, illustrating the fact that there is excellent endothelial protection. So create a nice central trough, and this Veritas is really excellent at sculpting, very efficient cutting machine. Using a two-handed maneuver, I'm rotating the lens 180 degrees. And I begin to sculpt. Again, very efficient cutting in the sculpt mode with this machine. Turn the bevel down, and then I slide the chopper under the rexus edge contra-incisionally, performing the terminal chop, fracturing the lens on the terminal side contra-incisionally, and then propagating that tear all the way proximally. This is the cross-chop maneuver. I place the chopper under the right heminucleus, pulling the chopper centrally towards the phaco tip and fracturing the lens in half. Using some vacuum to grab that first quadrant, and then crushing it and getting the chopper around it, and then crushing it once again, and then emulsifying the lens with the phaco tip. This machine is very efficient at lens removal. You can see how efficient the lens is being emulsified. You can see by the overlay how much I'm using aspiration vacuum and minimizing the ultrasonic energy use. Loosening the second quadrant, and then using some vacuum to grab the piece, getting the chopper around it, crushing it between the instruments, and then emulsifying the lens pieces. Trying to turn the lens, but it doesn't turn, so I use some vacuum and grabbing the lens and lollipopping and lifting it up. This machine has excellent holding power, so that's another thing I observed. Holding power and purchase power of grabbing the lens pieces is really superior with this machine. I'm able to just grab it so easily and lifting it up. And the pieces rarely fall off with this machine. Grabbing the last quadrant, lifting it up, and then crushing it, the lens pieces between the instruments, and then emulsifying the lens piece. Again, using some vacuum to help guide and position the last piece, and then getting the chopper around it, crushing it between the instruments, and then emulsifying the lens pieces. As I remove this last piece of dense endonucleus, again, please observe that bubble. That bubble is preserved in an endocoat trap. And that bubble, again, signifies and demonstrates how well the endocoat protects the corneal endothelium throughout this case. Removing the last remaining endonuclear pieces. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. And I really like this machine because as I remove the endonuclear pieces, it helps to preserve, and it really preserves the epinuclear and cortical pieces. So I'm able to remove the lens pieces layer by layer. So I start subincisionally. You can see there's a thin layer of epinucleus, which is fine because I'm able to peel the cortex from anterior to posterior. I go ahead and just peel the epinucleus 360 degrees, loosen it up, and that thin layer of epinucleus starts to tumble out. And then removing the cortical material first on the left side from anterior to posterior. And as I peel, you can see there's a little bit of zonular laxity as I do this. Peeling contra-incisionally. Again, trying to find the anterior aspect of the cortex. You can see foot pedal modulation is very important with this. You can see in the upper right corner my foot pedal modulation. Again, a little bit of zonular laxity. And again, this is a metal tip. This is not a polymer tip. So you want to be very careful in these situations. I switched to polish mode and I'm trying to polish the posterior capsule. You can see I puckered the posterior capsule, but I'm able to reflux and release it. And again, I puckered up the posterior capsule again here, but I'm able to release it once again. So there's some zonular laxity in this case, which again is typical in my experience with dense lenses, but no severe zonulopathy or zonular dehiscence. Pulsing BSS into the subincisional capsule fornix as well as the contra-incisional fornix. Turning off infusion and then pushing cohesive viscoelastic to fill the bag. Again, observe that that tiny bubble is still there. All throughout the endonuclear removal, epinuclear removal, as well as the cortical removal, that bubble is still there. Excellent endothelial protection with the Endocoat. So I'm sweeping under the rhexis edge, under the left side and then the right side, cleaning off the lens epithelial cells with the corneal sweeper. And I injected Helon Pro to fill the bag, and I pushed some more Helon Pro before I inject the lens. I want that bag to be nice and full. And I'm injecting the single piece acrylic lens, the ZC Boo, into the bag. You don't want to be too aggressive with this lens. This lens is rather stiff compared to the Acrosoft material, so you want to be more ginger as you go underneath the lens, removing the viscoelastic from within the bag. Repositing the lens back into the bag. Polishing under the rhexis edge. And so again here, I did endonuclear removal, epinuclear removal, cortical removal, lens placement, and that bubble is still there. That bubble is there throughout the entire case from the very beginning of lens disassembly. I think there's no better demonstration of endothelial protection with this Endocoat, which again, in my experience based on this case, is the most effective and superior endothelial coating viscoelastic that I've used thus far. My partner and I even commented that this Endocoat works so well that it actually takes a lot longer to remove at the end of the case. And so I use the Endocoat for very dense lenses. So if there's a dense lens or a small pupil that I need for viscodilation, I prefer the Endocoat to give me good viscodilation and supreme corneal protection for dense lenses. But you'll see in a future video that I also use the Helon GV as a single agent throughout the entire case for soft lenses. And I'll explain in that video why I prefer the Helon GV in those cases. But again, this video is really just to demonstrate how the Endocoat bubble trap can show you visibly that the Endocoat is protecting the corneal endothelium, because by maintaining that bubble throughout the entire case, it tells you that there's corneal endothelial protection starting from the endonuclear removal with terminal chop, cross chop, mechanical fracturing, and then switching to the IA, removing the epinucleus, the cortex, filling the bag with Helon Pro, and then injecting the lens, the ZC-BU lens at the end of the case. Despite all of those maneuvers, that single bubble with the Endocoat bubble trap still remained throughout the entire case, and this patient had a crystal clear cornea post-op day 1, and therefore, in my opinion and experience, the Endocoat is the single best dispersive viscoelastic for corneal endothelial protection. And so if that's what you're looking for, you should consider using this particular viscoelastic for your cases. So I hope this was helpful to you, and I thank you for your attention.